Hi guys, it's Dikshika and I'm presenting on the breech presentation. It's a most common malpresentation and the most common cause of the breech is prematurity, while the most common cause of the recurrent breech is a uterine malformation. It is of three types. First is the flexed or complete breech, second is frank breech, and the third is a footling breech. In the flexed or complete breech, there is a hip flex and knee flex, and per vaginally you will see the heel, buttocks, and the genitalia in case of the male. It is most commonly seen in the multigravida. Second is a frank breech, and you can see on per vaginally the buttocks and the genitalia in case of the male. It's the least chances of the cord prolapse is there and the most common in primigravida. The third one is a footling breech. In that one, hip extended, knee extended, and on per vaginal examination you will see the feet, and the maximum chances of the cord prolapse will be there, and we have to go for the C-section. The overall maximum chances of the cord prolapse is seen in transverse lie, then footling breech, and the knee presentation. If the head of the fetus is extended in breech, then it's a stargazer breech, and we have to go for C-section. The management of the breech, you will go for ultrasonography to confirm the diagnosis, to look for the type of the breech, to rule out any gross congenital anomalies, and look for the hyperextension of the neck. Then we have to check for the prerequisite of the external cephalic version. If it's not contraindicated, we will do it in OPD at 37 weeks. Then we have to see whether it is successful. For the successful, we'll send the patient back. If it's unsuccessful, we'll try the second attempt. Then if it's successful, then we'll start the oxytocin and do the delivery. And the second, if it's unsuccessful, we'll go for the elective cesarean section at 39 weeks. And if the fetal distress is present, we have to stop the procedure, we have to revert to the original position, and emergency C-section is done. Caesarean section is the preferred mode of the delivery, while the vaginal delivery is the assisted vaginal delivery can be performed. It is not contraindicated. But there are some absolute indications for the caesarean in breech delivery. These are the footling, knee or the stargazer breech, preterm breech, and when the C-section done if the weight is less than 1500 gram. Breech with post-maturity or the baby weight more than 4 kgs, twin with first breech, breech with the previous C-section, breech with any other complication of pregnancies like PIH, placenta previa, and the breech score 3 or less. The primary with breech is a relative indication for it. Then we have to go for the assisted breech delivery. In that one, the induction of the labor is not done. Augmentation of the labor with oxytocin and the artificial rupture of membrane is also not done. If any delay in first stage of the labor or the second stage of the labor, then we have to consider it as the CPD, that is a cephalopelvic disproportional, and we have to go for the C-section. Continuous CTG monitoring should be done. After that, there are some maneuvers that are used in the breech deliveries. The first one that we have to go for the mechanism of the breech delivery. The first part to be delivered is a buttocks, and the engaging diameter is a bitrochanteric diameter, that is 10 centimeter. Engaged if the bitrochanteric diameter crosses the pelvic inlet and with the decent anterior buttocks touches the levator ani muscle, and levator ani will rotate the buttocks 1/8 of the circle anteriorly clockwise directly behind the pubic symphysis, and then there will be the delivery of the breech extraction. When the buttocks distended the perineum, that is the climbing up of the perineum is there, then we will give the episiotomy. The first maneuver that we will use is a Penance Maneuver. In this one, it is used in the breech delivery. We have to unlock the popliteal fossa in the frank breech, and we have to deliver the breech. Then second is a shoulder delivery. For that we will use the Lofsitz maneuver. Here we can see that we have to rotate the baby so that the posterior shoulder becomes anterior and the delivery happens. Then anterior shoulder then again comes behind the pubic symphysis, and it is delivered in the same manner. The third is the aftercoming head over the breech. The first maneuver that we use is a Burns-Marshall technique. In this one, the delivery of the head in flexed position, allow the baby to hang on its own weight when the nape of the neck is visible, give suprapubic pressure which promotes the flexion of the neck, and hold the legs of the baby, turn it towards the mother's abdomen, and head of the baby gets delivered. The second one is the Mauritius smiley wit technique, in which let the body of the baby rest on the hand, then fingers of the left hand on the either side of the malar prominence, and on the right hand we have to put the fingers on the either shoulder as well as the middle finger on the occipital protuberance or the suboccipital region, and then with the help of the shoulder traction and the malar flexion, there should be the delivery of the aftercoming head of the baby. Then there we can also use the Piper's forceps and the Prague's maneuver for the delivery of the head. Thank you.